Good evening and a very warm welcome to the third episode of the very popular Master Techniques in Foot and Ankle Surgery. My name is Maneesh Bhatia, and on behalf of the Education Committee of BOFAS, I'm proud to host this third episode of Master Techniques tonight. We are going to talk about a very interesting topic, Tarsal coalition, and we all come across this area, which can sometimes be quite challenging. We have very distinguished speakers in Rick Brown from Oxford and Manuel Monteagudo from Madrid, and they are going to share their experience with us. So I'm sure you would enjoy listening to them, and feel free to ask questions through the Q&A function on Zoom, and I'll put your questions to the speakers if you have any. Just a reminder that after the discussion, there will be a QR code which you need to type in so that you can put your feedback in, and then you'll receive the certificate. So without taking any further time, I'm going to introduce Rick Brown, who is our first speaker. Rick is consultant orthopedic foot and ankle surgeon at Oxford, Nuffield Orthopedic Center. His practice involves a huge spectrum, and he does provide a transition overlap service. So he does come across a lot of patients between the age of 14 and 20 years who have tarsal coalition, provides the treatment. Rick is a very keen educator. He has chaired the education committee of BOFAS. He runs numerous courses, has been senior examiner of FRCS trauma and orth exam, and is also the president-elect of BOFAS. Rick, I would like to welcome you. Thank you very much for your time, and over to you for the talk.
Thank you very much, Maneesh. It's a pleasure to join you in the Master Techniques series. So I'll share my screen. Can you see that?
Yeah, that's good.
Okay, good. So what I want to do for the next 15 minutes is really to talk about this very interesting topic, and to discuss where I see my management plans and where I'm thinking how to manage these, and also then come on to some of the controversies. And I'll set the background and talk about some interesting twists at the end, and then Manuel's got some interesting twists to talk about, and then we'll take lots of questions. So really, there are two main common types: the calcaneonavicular coalition, which is the friendly little pussycat, and then there's the talocalcaneal coalition, which is the nasty leopard who's going to bite you if you don't know what to do. They can all present with rigid flat feet, with hindfoot pain, which is worse than activity, recurrent sprains, and they used to be called perineal spastic flat foot because of muscle cramps. On examination, they have rigid flat feet. This is a very stiff subtalar joint. There could be tenderness on either side. And already at this stage, you need to be thinking about what's the alignment of the hindfoot, because that is going to be crucial throughout this next hour of discussion. But also, in the real world, they're not always stiff, and they're not always planovalgus. Their age of presentation really varies. It depends on which coalition. They can present early when the cartilaginous soft coalition starts becoming stiffer. That's at a younger age in the calcaneonavicular than the TC coalitions, or it can occur later on in adolescence whenever they have some stress reactions around the coalitions, probably when they're having growth spurts. But then in our adult population, we see them later when they develop degenerative changes in the neighboring joints. They make up they occur in 3% of the population, and traditionally we believe the calcaneonavicular ones are the most common, and talocalcaneal being the next most common. And always beware if you spot one to think about a second coalition, and as they occur in 2 places in 30%. So these friendly little pussycats, you want to take an AP oblique, you can see the anteater sign, but in reality, there's a continuum of these. the MRI might show a clear anteater sign, but might just see a very pointed snout, which just touches the navicular, and they can also cause pain and stiffness. Initially, a trial of conservative management, and if they continue to give pain, then consider operating. And for the calcaneal navicular, it's fairly straightforward. They have good outcome from an excision. There are always debates about whether to put in fat or piece of muscle. And you can see in this slide below the large chunk. I think it's always important to take away a large chunk, about a centimeter cube. Often, or some of the patients I see bouncing back are ones that have had too slim a slice taken out. So take a big chunk. Now, what about the other side of the coalitions, the nasty ones? Always do standing x-rays. The Harris axial view is helpful, the C sign and the tailor beaking. We'll talk about these in turn. So the C sign was first described by our beloved Anthony, and it's seen and is helpful, but it's not always present. It can be found in other conditions. For example, in severe flat feet, you can see a C sign as well without a coalition. There are incomplete C signs, which can be misleading. So you can see these little white arrows, you can see the indents, and then the tailor beaking is often been thought to be a sign of a coalition, but actually this is more of a stress phenomenon. It's been shown by the Melbourne group to be just as present in patients who do well as patients who do badly. So it's not really of any prognostic benefit either. So which investigation should we do? MRI or CT for these? MRIs are the most useful go-to when you're trying to work out what's going on, because you can exclude a whole wealth of other conditions. But when it comes to planning your operation, I think it's the most important test is the CT, because you can really see the shape of the coalition and start to plan your surgery. It's nice if you can have access to a standing CT, because then you can combine the anatomy with the presence of a deformity. And on the CT, the most important thing I look for is whether there's any degeneration, because that's going to influence how we plan things going forward. This very leading team in San Diego described how to think about TC coalitions, and they divided them to 5 different shapes. And this is a good discipline to get into, because then you can start trying to work out how you're going to excise these or deal with them. So this is the commonest. It's fairly horizontal, and it goes through the middle facet. Whereas this one is quite a difficult one to deal with. The next commonest, type 2, because it hooks down. So if you're trying to follow a fibrous coalition, you can get lost. So by knowing about this in advance, it helps you guide your plane of resection. They can be fibroosseous, so a little bit of shingling, or they can be completely, that's the fibrosis, or they can be completely ossified and then bridged across, which can be the ones that present 10% a little bit later. And those are all in the middle facet. There's a rare version which extends into the posterior facet. So by CTing, and you can start to get an idea what the trouble is, and that's a breakdown of the frequency. My current, the classic management was to trial non-operative management, and 30%, a minority, but a significant minority, will settle without the need for surgery, but they nearly always go on to need surgery. Their surgery and their outcome is much less predictable. Just remember the picture of the cat, the wild cat. In adolescence, the traditional teaching was to do, if there was a small one, then you do an open resection. And if they were older, or there were large coalitions, or had any deformity, then you need to do a fusion, along with correcting any deformity. But I think it's become clear in my mind, and it's a bit simpler than that. Yes, try conservative surgery, deal with any deformity, and then if there's no degeneration of all types, I go to resection, whatever the size, and if there's degeneration, I can go to fusion. So deformity is the least controversial area, but what's the cutoff? 15 degrees of valgus is what I practice in my hands, and that's based in San Diego group, but others have used other cutoffs. And there are different ways of doing this. You can do lateral column lengthenings in the adolescents, or a sliding calcaneal osteotomy, which I tend to do in the older and the adults with a MIS technique. And there you can see this is an example of a benefit of doing a lateral column lengthening, how you can see that good correction of Mary's angle, and also how you can correct the abduction of the talonavicular joint. And if there's a lot of abduction of the talonavicular joint, that would push me to a lateral column lengthening to correct the deformity, as well as deal with the coalition. There's no real evidence, there is occur in too small numbers. There's no randomized controlled trial to see which is the best if you're trying to base it on evidence. So the dilemmas I currently have are what age to operate on, whether you should resect or fuse, whether if you're going to realign and resect, should you do them at the same time or separately, and then which technique to use. So the age, this has been clarified. There are growth curves for feet, which you want to be operating not in this growing part if possible, but more in the static level. But actually the Melbourne team did show that outcomes are independent of age. So you should operate when they become painful, when they become having symptomatic stiffness. Whether to resect or to fuse this, the traditional classic teaching was all based on size. And this goes back to 1987 when Scranton used this criteria, which has been rattled off again and again as the religion in the FRCSO, with about 50% of the coalition. If it's less than that, you can resect. If it's more than that, I think really that's outdated and we've moved on from that. That's the teaching. The little diagram shows the open approach, and that was the original cutoff, but that's probably more dogma than reality. The Melbourne group, they started to look at different ways of measuring this, and then there's confusion in the literature because different people use different criteria. But coming back to my point, which we'll discuss later, is that probably the size isn't so important. The method I do tend to recommend if you are going to measure them, this is a little diagram of bar charts, but you can do it with get your radiologist to do it arithmetically by programs to measure the ratio of the coalition across the middle facet compared to the overall subtalar joint. But this is, I think, more useful. And it's a very big paper compared to all the papers in the series, 93 coalitions. That's a great series to collect. And this was the team in San Diego. And they excised all of their coalitions and then went on, if there was a deformity, to do a second stage procedure. And they had very good results. So I tend to base my current practice on their work. There are some criticisms of the paper, and that they didn't manage to get preoperative CTs and some of the postoperative CTs in all their patients. So if you are going to realign, should you do that at the same time? Well, it does seem a bit strange to do an operation to gain movement and then to realign bones and set patients in casts for 2 to 3 months to get bony union. So those two things are going against each other. So I think I like the idea of trying to do minimal interventions. So if you can do an arthroscopic resection, then an MIS calcaneal shift, then you can try and get early movement if you're going to do them at the same time. Or you may stage, get the movement, and then do the realignment later on. Which technique to use? Open has been the traditional teaching. I'm just going to cover the option for arthroscopic. People did a little bit of arthroscopic assistance at the beginning. So they would look in the sinus tarsi, see both sides of the middle facet, put some wires through, and that would guide the open approach. Then the posterior approach became popular with Barcelona. And I used posterior arthroscopy for lots of things, but not for this. And they would look down past FHL, and you'd see the tarsal coalition of the middle facet is very nearby, very near the neurovascular bundle, and they would excise it. You can see their burr very close to the neurovascular bundle. The technique I prefer for arthroscopic removal is this sinus tarsi approach, first described by the Southwest team, Ian Winston and Steve Parsons. But in their initial series, which is now 9 years old, they had a very high 12% rate of tibial nerve injury, which is, I think, an example of a learning curve paper. This is a patient of my own, middle facet. If you look very carefully, just as a clue of how difficult it is, there's a little piece of metal in that patient's posterior facet because it's difficult. Oh yes, there's the one with the metal. But this is another patient with views. You can see the coalition. What you want to do is get in there and define with a burr, define both sides, and then you can get your small 2.9 millimeter bone burr in, gradually making it smaller and smaller. You can see there's a little bit remaining in the blue dots. And then finally, I'm pushing through with my probe to the capsule and the inside. So it is tricky. It takes practice, but the patients do so much better than my open resection patients. They are up and mobilized, and they look at you strangely when you ask them if they have any stiffness at 6 weeks. It really gets them moving more quickly than the open operation. So in summary, my recommendation for TC coalitions, always get some standing imaging, do a trial non-operative measurement, and look hard for any degeneration. Degeneration is the key. If there's no degeneration, if it's a small coalition, then definitely resect. If there's hindfoot valgus of greater than 15 degrees, then also realign. Do a post-op CT so you can learn. So that's the pre on the left and the post-op with a big hole through the middle facet, just to prove to yourself so you get better. Now, if it's a large coalition, then I'd probably use resect, but I'll do it by an open technique. And again, this concept of, I use the cutoff of 15 degrees to realign. If there's degeneration, and really there's not been enough time to talk about degeneration, then unfortunately, more in the young adults, you need to go down the avenue of a fusion. So with no deformity or less than 15 degrees, then I'll fuse in situ. So I'll try to do arthroscopically. If it's a large deformity, then you'll need to do a correction, and that might even be a triple fusion to get the correct alignment. So hopefully that's a guide to my current thoughts that might change next month on how to tame the wild cat of the tarsal-talocalcaneal coalition.
Thank you, Rick. That was a very good, very concise, comprehensive review of this complex and challenging problem. We'll do the discussion bit later with both of you. So I'm now going to ask Manuel Monteagudo, who is again very senior, respected foot and ankle surgeon from Madrid. He comes with a different philosophy on tarsal coalition, and I'll let him talk about that. For those who don't know Manuel is again a great educator. He is a current chair of the scientific committee of EFAS and president-elect of the Spanish Foot and Ankle Society. Over to you, Manuel, and thank you very much once again for giving us your time.
Thank you very much, Maneesh. Thank you very much for the invitation. Thank you for having me. I'm honored to be here in this forum. I will talk about, again, tarsal coalitions, but I will specifically refer to when to realign without resection and what is our current experience with this. I'm based in Madrid, Spain, and I work at this private university hospital, and I've been fully dedicated to foot and ankle surgery, both orthopedic and trauma, for the last 20 years. I also teach orthopedics at this medical school nearby my hospital. I work in professional education for these three companies, but there's no conflict of interest with my presentation tonight. Well, regarding talocalcaneal coalition, my experience is that most of the times they're associated to a plantar valgus deformity, but obviously most of them are not symptomatic. And when they are, they come up with pain and instability in most of the cases. I'm bringing you this video from the film Witness. Some of you will possibly remember this. To talk about the MES population in North America, and what is funny about the MES population, among some other things, is that they have a high incidence of tarsal coalitions, and they have a high incidence of talocalcaneal coalitions, but the literature says that the CN coalitions are more frequent than the talocalcaneal coalitions. In our experience, reviewing a series of coalitions, we have the same experience as these authors, and talocalcaneal coalitions are more frequently diagnosed and possibly more frequently symptomatic than CM coalitions in our practice. So this is what we have to deal with the ugly one, and then again, most of them do present with a flesh plantar deformity that may become symptomatic, but hopefully most of them will respond to conservative treatment. So the same type of insults we get for a symptomatic collapsing full deformity might do well for a talocalcaneal coalition. Although they might be maybe rigid, or they are rigid sometimes, they still move through the short part joints, so they may do well with insoles regardless of the stiffness of the subtalar. And as Rick said, well, there are many factors that may influence the choice of treatment for when it comes to surgery. These are all factors we took into account in the past, and we also take into account. So an isolated resection might be considered in cases with children under 16 years of age, less than 50% of involvement of middle facet relative to the posterior facet, no arthritis, obviously, and a normal alignment with that. But again, there's not much of a consensus on this, and again, there's no much of evidence when it comes to for isolated resection, and they're not free of complications, as Rick showed you. So some other authors go for resecting and stabilizing at the same time, especially when there is a valgus deformity associated and no subtalar arthritis. The question with you do both the resection and realignment and the patients go well is which is the relative contribution of each of these procedures to the final outcome. That was something that we wondered for a long time, and I'll come back to you later with that, with a current approach to that. And finally, arthrodesis is another option. Obviously, in the presence of excessive subtalar joint arthritis, valgus deformity, and a big coalition, you may go into an arthrodesis. But again, there's not much evidence on arthrodesis on a talocalcaneal coalition. Some authors say that we just resect and fuse, and some others say that it should be it should have a bone block put onto the subtalar joint fusion. Our experience with the arthrodesis is that they're possibly more complicated in the end than getting down to a normal subtalar joint arthritis, post-traumatic arthritis. And again, you think that subtalar fusions have around 15% of non-unions. Think about possibly having at least that in a when we're dealing with a talocalcaneal coalition with arthritis. So, are there other possibilities to deal with talocalcaneal coalitions? We believe they are. Resection and realignment is one of the way to go, and realignment without resection is what we've been researching over the last years. The paper by Mosca shows us the way to realign and resect. And what they do is that they realign by doing a lateral lengthening osteotomy on top of the resection. But if you have a look at the conclusions, they said that the treatment of valgus deformity is to be as important as the resection of a coalition. We believe it is even more important, and we believe it is the most important thing to do possibly. So again, which is a relative contribution of the resection and the realignment to the final outcome. That's something that is still to be answered by any paper, to my knowledge. And then there's some other questions that we might discuss later on. But why does a talocalcaneal coalition hurts? And people come out with pain after 25, 20 years of age. Why is it been asymptomatic for years? Some also say that bone stress injuries in the presence of tarsal coalition may be the cause of onset of pain in young people, but they say that there might be stress fractures around the coalition that might be responsible for pain. But we indeed, following our research, clinical research on collapsing flat foot deformities, we believe that it is a soft tissue stress and the collapsing foot that is possibly the problem underneath the pain in a talocalcaneal coalition. And why is it asymptomatic for years? It's possibly because the compensation mechanisms do work for a long time, and then the patient has a lot of these compensation mechanisms from other foot structures, and then they become symptomatic at a certain age. And the restoration of the middle arch, we believe it is paramount to get a sound mechanical base to get this patient free of pain. As I told you, most of these patients, if you look at the MRIs, it is actually the soft tissues that are into trouble rather than the coalition itself, which is not so much edema in most of these cases. So we decided to go the other way around with this, and we show you cases on an approach of just a realign with a resection. This is a flat foot deformity, 90-year-old athlete. She had disabled medial ankle pain for 2 years. I had this presentation. You may see the C sign there on the right, and see how one of the ankles is lower than the other. And on CT scan, see how the massive bony coalition, TC coalition. That was a gait. On visual gait analysis, she obviously had a flat foot deformity. and she complained of pain around the medial side of the ankle. So we believe that most coalitions that present with pes planus do share the same pathomechanics and possibly the same management strategy as we do with conventional pes planus. So we went that way in this lady. We had an isolated medial slide calcaneal osteotomy, and if we didn't touch the coalition, the coalition, she changes 1 year post-op, say that the medial arch has been restored, and the ankle is now the same height as the contralateral healthy ankle. So apparently it doesn't move because it's rigid, but it does move through the short part, and the short part is compensating towards getting non-collapsing foot again. And that lady was free of symptoms. So we do believe the osteotomy, the isolated osteotomy, has a lot to do with the final outcome, mostly than the resection of coalition. Just imagine this guy being the spring ligament of the medial soft tissue structures. How would you help him? Will you help him just by getting a couple of boxes away? And that's what the osteotomy does in these patients. So when we restore the medial arch through the osteotomy, the medial soft tissue stress possibly goes away. If you think about this is much easier to collapse. If we restore the medial arch, that will get patients get better. And this is Brunelleschi, and that was the dome of the Florence Cathedral that collapsed when they were building it. And Brunelleschi had the idea to build it higher and heavier so it didn't collapse. And they thought that he was crazy. But here it is, quite a few centuries after the building of the dome, this is still there. So restoring the medial arch is vital in these patients, we believe. And just let me show you a couple of different cases on Taylor or different coalitions to see how these principles also might be applied to other coalitions. 55-year-old librarian, disabled mid ankle pain for years, no big improvement with insoles. And again, she is presented with a flat deformity on visual analysis. And again, it's the same scenario. The one ankle is lower than the other in the AP views, weight in both ankles. And you see there's a Taylor beak there, and you see there's a calcaneo keyboard coalition, massive calcaneo coalition bilaterally. Regarding Taylor beak, as Rick said, it is not a degenerative problem. It is the tailor navicular has to work as a calcaneocuboid in this case, and that is it develops a tailor beak to stop movement. If you have a look at this tailor navicular joint, it actually reminds us of a calcaneocuboid joint, which is not present because it is fused. And in this lady it is a rare case of coalition. Most of these calcaneocuboid coalitions are associated to syndromes, like these Clouzon syndromes, X1-Weiss syndrome. But this lady had not of these syndromes. It's just this isolated coalition. So when we went the other way around and just performed an isolated calcaneal medial side calcaneal osteotomy, didn't touch the coalition, just leave her. And again, that was restored to the normal height of the ankle. And this lady was free of symptoms after just the isolated osteotomy. And again, with just one last case, this is a 48-year-old, again, medial ankle pain. And we found this massive coalition with Wollen socket here. And that was the pre-op, and that was the post-op following just an isolated calc osteotomy, medial calc osteotomy. It was not perfect, as you may see in the X-ray, in the ankle X-rays, and it still had some impingement, superior impingement, but she was fine, and she was much less symptomatic, and that might work in ball and socket situations. We have massive tarsal coalitions there. So we still have a lot to think about this a lot. We need more papers, we need more evidence, obviously. So ideally, we should set up some multi-center studies to compare what are the options with just the isolated resection realignment, what type of realignment, or just realign without resect, and finally, which cases should go into primary arthrodesis. So the take-home message would be the tilo-calcaneal coalitions most of the time is presented with their pes planus, and they behave with medial soft tissue stress. And osteotomies have been working in our hands so that they can the procedure choice in our patients. And most of the times there's no need to resect the coalition, except in the CNs, as Rick showed us. Thank you.
Thank you very much, Manuel. That was fantastic as ever. This brings us to the discussion now, and based on our previous feedback, I think giving more time to talk about the problem with the two very senior and experienced guys is going to be quite useful. So I'll open up the discussion with a couple of questions from the audience. So the first question is regarding the conservative or non-operative treatment. So the question is, what does the non-operative management mean for you, and how long do you persist with this before operating? So Rick, you go first.
We have a standard unit of orthopedic time is 6 weeks. So if the patient comes to me without a long previous referral, a new case, I'd suggest they go into a boot for 6 weeks and then to avoid impact activity and springing activity for another 6 weeks or 3 months afterwards, try and get them back to activity. But quite often when they come up to Oxford, they've tried these things before. So the patients don't want to go back and try that again. The other thing you could try non-operatively is injections. They are more amenable to having injections, and I find injections are more helpful in the calcaneonavicular coalitions than the ST. I'm not sure, Emmanuel, how do you find the difference of responses to injections?
I do not inject very much, really. I have no much experience with injections. I just we're now in those cases we have doubts of what is really the problem. We're now more into doing SPECT CT scans, which shows the ideally the location of where the edema and pain is around, rather than to inject. But I mean, it might be a useful way to go. Obviously, I have not much experience, I can tell you.
So,
yeah, sorry, go on, Maneesh.
I was going to ask about the non-operative regime. Do you have any fix? Is it just insoles, physiotherapy, exercises, Manuel, and for how long do you try it?
I basically try insoles. I believe it is clearly a mechanical problem, and the problems to be possibly managed mechanically as well. Our experience with physiotherapy and other therapies is very limited in terms of getting pain relief with just sole time. But insoles can make a big difference, and most of them they do. I mean, most of our patients do well with insoles, and they don't need surgery at all. So it's always, at least I believe that the use of insoles for around 3 months would be ideal before indicating any type of surgery. And if the patients are not very limited in terms of pains and functional activities, I just leave it with insoles for as long as they need. I'm very conservative in terms of indicating surgery. So
for the patients that come to me that benefit from the insoles are the ones that come to me with hindfoot pain. My patients are kind of two groups. There's the ones that come with pain and the ones that come with stiffness that's limiting their function, like the gymnasts, the footballers. The ones who come with the deep pain do quite, I find it's a much more mechanical alignment issue, and the insoles are helpful. The ones that want to get movement don't do well with those. Okay,
thank you very much, both. The next question is to you, Rick. So Manal Siddiqui has asked, do you worry about detaching the tibio-sustentacular portion of deltoid ligament after excising the talocalcaneal coalition?
Arthroscopically, my fear is much more of the neurovascular bundle. And I've not found any medial instability afterwards, either open or arthroscopically. Open, they're probably too stiff afterwards. I think it's quite possible you could detach the deep deltoid, because especially if you get lost, and to be honest, people, I mean, you can get lost if you don't have a good preoperative imaging to work out exactly where the line of the coalition should be. It can be at risk.
So I'm just, as a follow-up to that question, I'm not asking Manuel because he doesn't believe in excising, but Rick, your approach to excise, is it a medial approach if you're going to do an open approach, or you don't do an open approach at all?
So I've slowly moved my practice more arthroscopically, and I'd prefer to do arthroscopically for a smaller coalition, smaller patient. So if you've got a big, I can think of some rugby players or some shot putters, really big people, I just can't get into them, then I'll do those open. And then it'll be a medial approach every time. And one of the tricks to the medial approach is to put a blunt end of a K-wire into the sinus tarsi and push that out to the front and the back of the coalition, so you can at least find the plane that you need to resect. So you shouldn't end up drifting inferiorly and shouldn't detach the deltoid, and hopefully should stay in the safe zone away from the neurovascular bundle posteriorly.
No, absolutely. That's a very good tip, because that's the worry. You don't know where to start resecting. And as you said, that putting something like a guide wire in the sinus tarsi region can quite help you. Manuel, it has been asked that if you're talking of a realignment procedure, is there any role for spring ligament reconstruction or arthroresis screw?
Well, regarding spring ligament and the medial soft tissues, we don't repair them. We believe that the soft tissue stress there is very much alleviated by the bony procedure. If you take the weight away from the medial soft tissues, the medial soft tissues will be fine after a time. For those who may try an osteotomy, if you get a patient who is doing fine and get an MRI 6 months down the line from the osteotomy, all the edema and the soft tissues are look good looking at the MRI. So we don't think, regardless of the state of the medial soft tissues, we just don't repair them primarily in any case. We still do the isolated calc osteotomy, and pain goes away. And regarding the arthroresis procedure, which is, I would possibly consider it in the setting of a CN, but not in the setting of a TN, of a TC coalition. And it's in the setting of a CN, whichever, it's a totally different game, although they are called coalitions. It's a totally different game. But in case of a talocalcaneal, again, it is pretty difficult to restrict movement when you have a bone block. And then if you resect the coalition, what do you need to restrict movement? I don't believe much in mechanics after resection of coalitions. That's one of the reasons why we moved to an easier procedure and just started doing one by one procedure, just getting the isolated calc osteotomy. And as it worked in most of our patients, we stopped there. So we didn't associate any other things to the calc osteotomy. We didn't feel the need to do it really. And our patients were pretty happy with the isolated calc osteotomy. Arthritis is again a bit of a problem. Again, overcorrection in these patients is an issue if you do an arthritis. You always tend to use a big implant, especially when you have resected the coalition, and then you need to stabilize that. So I've come across patients referred to me with a valgus deformity after a valgus correction, after resection and arthritis, and that is a problem. That is a big issue.
Any thoughts from you, Rick?
An arthroresis screw seems to be counterintuitive to me. You're holding this in my ideology to get movement and then to put a block into it. You should correct the deformity extra articulately with whichever technique you choose.
Thank you both. The other question, the next one is for you again, Manuel. So you talked about pain. Most of the patients, people have medial pain, but if someone has lateral pain, are you going to do the same procedure?
That's the same as in a collapsing fractal deformity and a painful fractal deformity. You come across the flexible cases or rigid cases in which they have more lateral pain than medial pain. It depends on the state of the thin end and how the subperoneal subfibular impingement does work on the peroneals. So then I think that if a patient has lateral pain, that is because of the collapse and the subfibular impingement rather than any other problems. Of course, they get an MRI to just rule out any lateral, any cause of lateral pain. But again, if they have a valgus alignment, I just go and do the realignment without doing anything from the perineals, unless they have obviously a structural problem. But it's not the case in most of our cases. They may have lateral pain as well. But again, if you realign them correctly, lateral pain goes away, as it does in a flat foot, conventional flat foot deformity without a coalition.
Thank you. The next question is actually from one of my Leicester colleagues, a pediatric orthopedic surgeon, Anna Peak. So she's asking you both, what is the youngest age? Well, she's asked Manuel, what is the youngest age you would suggest an osteotomy without resection? But both of you can answer that.
That's a good question. With the youngest I can remember I did was 15 years old. And then again, we tend to go for the isolated medial slide rather than the lateral lengthening osteotomy, because I know most can, and some of these of our pediatric colleagues are very much want to go through a lateral lengthening, which obviously do realign correctly. But my worries about realigning through a lateral lengthening procedure in an adolescent is that they're not that flexible and they're not able to sometimes cope with a big lengthening. So we've come across a case of a lateral lengthening procedure in the context of a talar calcaneal collision, and getting the pediatric patient have calcaneal cuboid pain and developing a lateral column syndrome after the lateral lengthening. So again, I would then advise, if you do lateral lengthening, to our experience, an 8-9-year-old can take anything you like. It can take 15 to 20 millimeters of lengthening, but if you're doing that in an adolescent, we shouldn't go farther than 8 millimeters of lengthening. Otherwise, they might get into having calcaneal cuboid pain, although get better from the pain associated to the coalition. And then my answer would be yes, I go possibly until the age of 15, but it is very rare. They're very rarely symptomatic at the age of 15, 16, to being able to not to respond to insults as well. So I'm very conservative at those ages.
Thank you, Manuel. What about you, Rick?
Yeah, I think you should be very conservative in the younger age groups. And that slide I showed of the growth curve for feet, I think is important. And you want, if you're going to be doing realignment surgery, you want to wait till they've got onto the plateau phase of that. So yeah, girls 11, 12, boys 13, 14, if you're going to do realignments. I think the youngest I can think of would be about 14. And I decide between the lateral column lengthening based on the talar-navicular abduction, and I never go more than a centimeter. It was probably an 8 millimeter cut and then the size of the saw blade, so centimeters as much as I'd try and achieve. But I find that's enough for that degree of deformity. The deformity is so key, and I'm glad that we're both talking about that as a key measure. But sometimes it can be quite hard to convince yourself to operate, even in a 20-year-old who's just gone to university, he's having a prime of his life or her life, and then you can say, I'm going to take a year of your life to realign you because you've got this 10-degree deformity or 7-degree. What cutoff to use? It's easy when they've got a 25 or 30-degree deformity, but what cutoff do you use to realign the coronal deformity, Manuel?
That's a good question again, and I can't really tell you on any evidence on that. We've been doing that as long as the patient has symptoms related to the flat foot problem, and as long as there's a valgus, which is obviously correctable. I would say this. I cannot measure. We don't measure degrees of valgus. We don't do that. But then any valgus deformity associated to pain and a talar-calcaneal collision, in our hands, we'll start by just doing the isolated calc osteotomy as a first measure. Obviously, we would tell the patient that they might need more in the future, and they might need more surgery. Obviously, there's obviously the possibility of having a degenerative problem in the subtalar, needing a fusion or whatever. But again, our experience have moved away from resection on these patients, or combining resection to realignment, because resection is associated to so many potential iatrogenic problems, as you showed. That we were very worried about that. When I started in the practice, I had a couple of cases referred from other colleagues with apparently the right resection getting down to the sustentaculum tali and losing the flexuralis longus, and another one which is not resected at all. So I thought that in my hands would be very difficult to perform the correct resection. And there's so many variables around the tail of calcaneal collision that is, as you saw arthroscopically, it is so difficult to get the right reference and knowing when to stop and how much to reach. But on the other side, a conventional calcosteotomy is just a 10 millimeter slide. You get a patient way better in a couple of weeks in the boot, and then it will take them a couple of months to come back to living normal life, getting back to school or university, and 3-4 months for sports, which is not that long in those cases if you do an isolated calcosteotomy. But it might take long if you perform a resection and realignment. That would possibly get them longer and long way better. But that was another of our reasons to move away from resecting and just start with realignment first.
Thank you. I think you've already answered the next question, but I'll just ask again. Manuel, is there any time when you would resect rather than correct?
Not really, not at the moment. I haven't resected operation for the last 70 years, I'm afraid. But again, there's the odd case in which you come across a different case. I mean, it's not all black and white, I suppose. And possibly I'm talking about this and getting my clinic tomorrow a patient with, possibly I'm not very comfortable with just performing an isolated osteotomy. Of course, I have doubts, and I have doubts every day about those patients who come with signs of arthritis, but they're not very arthritic. And again, my question is, why does it hurt? Which is the structure that hurt? And whenever I very occasionally ask for a SPECT CT scans in my practice, very occasionally, but that's one of these patients in which I'm not really sure whether the pain comes from the subtalar, the middle soft tissues, or both. We'll just go for a SPECT CT, and if there's subtalar involvement, and just say to the patient, I'm going to do the osteotomy first, but you might possibly need something else in a year or so. To our surprise, we have 2 of these patients. We're now actually preparing the paper with a first series of just isolated calcosteotomy on bony tail calcaneal collisions. And 2 of these guys had clear signs of subtalar arthritis, which in our hands would have gone to an arthrodesis in the past. But we just did the calcosteotomy, and they were much better. And the CT scans showed big improvement after just the calcaneal osteotomy. So that arthritis was possibly being influenced by the malalignment. Just some food for thought again. We have no evidence. We have only 15 cases with more than 5 years, 5-year follow-up. So it's not big numbers to tell you that I'm 100% sure of the way we go.
So Manuel, in your investigation sequence, do they all have an X-rays? Yes, and then MRI, and then the SPECTs? Because I agree with you that soft tissues can be the source of pain. But do you ever get patients who have a SPECT that's quiet, that there's no bony uptake?
Right. If the MRI shows no signs of subtalar wear or arthritis, I just stop there. I don't ask for a SPECT CT scan. But if I have doubts about the subtalar edema, signs of swelling around the subtalar, just ask for a SPECT CT in those cases, which is possibly 1 out of 10, I should say. It's not very frequent, in which I have doubts whether how much the contribution of subtalar builds up to the final pain. But in those we ask for a SPECT CT, 2 of them have these signs of subtalar arthritis that might be a completely fresh indication for fusing. We didn't fuse at the beginning because we're feeling that the isolated calcosteotomy might work in those patients, and they did. And they did. But there's only 2 patients I can tell you that in most cases would work, but it still needs some investigation. So this is a good way to go in these forums with so many people attending, is that check your patients and see if you do just a realignment procedure, get a new MRI, get a SPECT CT, see how it changes 6 months down the line from surgery. And if it does, it's possible that the isolated calcosteotomy or the malalignment is possibly contributing in most of the pain, and it's also contributing in most of the relief for the patient. That's the way we're clinically researching this. I don't know if there's any other way to research, apart from these clinical studies in which you actually try to isolate one of the procedures and not doing the other, as we did with just the isolated scalp osteotomy, skipping the resection or skipping other procedures. So we started with the osteotomy because we believe it had, as in the conventional adult platform deformity, it had most of the relief for these patients, and it is apparently working as we are doing in a conventional approach to flexible platform deformities at the moment. We're not doing any more FDL transfers. We're not doing any more spring ligament repair. We're not doing any more tibialis tendon procedures when we have a flexible stage 2A, 2B deformities. So we don't go into the soft tissues at all anymore, just do the bony procedure. And if you get an MRI down the line, 6 months down the line, you see how pain is gone, but swelling is gone, and you have no signs of problems around the major soft tissues. And that was a way to go, to just try to simplify the procedures and getting away from causing more problems to the patient. That's the way we reach a new way to proceed.
Question to you, Rick, from one of the Shakir Hussain, one of our listeners. What is the rate of reformation of the bar or coalition, so recurrence in talocalcaneal coalition? What is your experience?
Probably, I guess it's probably about 125%. And it's just, is it reformation or is it inadequate clearance? And that's probably why, whilst learning this new technique for arthroscopic resection, that's why doing post-op CTs, because you can be pleasantly surprised, like the nice one I chose to show tonight, or you can be pleasantly horrified by how little you've taken. So inadequate resection is a problem, but that's why feedback and doing CT is good post-operatively. And
similar sort of question to you, Manuel, which I was going to ask. So I'm not going to ask you about the recurrence of the bar because you don't excise it.
100%.
but what do you do in terms of failure? So if you have done, for example, a calcaneal osteotomy and the pain is still there, then how do you approach that patient?
Mm-hmm. If I do calcaneal osteotomy and the pain recurs, then I went to an EU MRI, and if there's swelling, it's just a swelling around the across the subtalar joint, and then I would possibly plan a fusion regardless of the age of the patient. But then there are very occasional cases in which we have done fusions in that setting, and most of these times I can't remember 2 or 3 fusions on talocalcaneal collision with loss of degeneration in subtalar and loss of edema and pain in subtalar as well. And we did that, and there were people in their 50s. So it's not the young athlete or the young university student in which you have to deal with the problem and the conflict of what to resect, to realign, and to go. So very, very rare case, and in the 50s in our case, in our experience.
Okay. And again, I think we talked about this before. One of my colleagues, Alistair Best from Leicester, has asked that if the foot is normally aligned, then do you do a heel shift to put it in varus, slight varus?
If the foot is normally aligned, and well, I would try not to operate the patient. Really, I need to find a mechanical reason why things happen. Sometimes we cannot find them, but most of the things happening around the foot and ankle, because the foot and ankle have a mechanical basis, and sometimes we just miss the course. And if I'm not comfortable with having a bar with a talocalcaneal bar, the right alignment, and just I will possibly be very much worried about setting up an indication resection, but I will give it a thought, really, and I wouldn't be comfortable with indicating surgery in those cases, which again, they're very uncommon in my practice, very uncommon. I was trying to recall any case of having a right alignment with pain, I will just give it a thought, really.
Okay. Thank you, Manuel. I'm afraid people are asking a lot of questions about realignment. So another question is there any other procedure you do along with the calcaneal osteotomy? For example, do you ever perform cotton osteotomy as well for somebody with coalition and valgus?
I would just, in the case of adolescents, I would possibly think that a lateral lengthening procedure would work, but then it is simpler to go and get a calcaneal osteotomy, a medial slide in the posterior tuberosity, rather than go and do lateral lengthening. Again, it is a question of what is more complicated and what may give more complications in the long run. Sometimes you don't need to get a perfect correction. You don't need to get a perfect looking X-ray. As I show you, some of the ball and socket zone had not a good looking X-ray, but the patient was happy. And again, with corrections in terms of having too much valgus, I don't tend to overcorrect and don't tend to approach to zero at all. I just think that a 10 millimeter medial slide will work in most cases. I even try to go to 12 if I have a big deformity, and it's the same with the lateral lengthening. I would possibly consider lateral lengthening in adolescents rather than medial slide. But again, they're very seldom operated at those ages. So most of the times I had the 20, 30-year-old, and that will do fine with a calcaneal medial slide calc osteotomy, which is primarily more stable and easy to recover than a lateral lengthening procedure.
Okay.
Maneesh, can I ask Manuel a question? Because this second group of patients, of our patients who come with their problem isn't so much some pain as the stiffness. So in Oxford, like it's the dancers, it's the gymnasts. Presumably in Madrid, you've got lots of flamenco dancers all wanting to have movement. I'd find it very hard to sell an operation that didn't give the patients movement. And that I'd find difficult to my cohort of patients.
Right. My question would be, I haven't got an answer for this, but my question would be, if you get a talocalcaneal resection and you get the bar away, and you get patients to be studied 1 year down the line for resection, I would just say, how much does it move, and how do you know it is moving? Because that's really a difficult thing to actually research and see how movement builds up around a place which have been not moving for a long time, for years. So I cannot find an answer to actually get the patient say that I will be able to get that talocalcaneal joint moving back to movement again.
You're right to make a very important point. There's a difference. You can promise I can promise my patient some improved movement, but not normal movement, not like the other side. It will be different movement.
The thing is that you said that if you take the data into account, you possibly see about 25% of them would possibly rule again the coalition, and they get a new bone bridge over that. So you take about a quarter of them will move again, and some of them will move less. So again, I don't think movement through the talocalcaneal joint is the key. I think the movement through the short part joint is the key in these patients. Restoration of height, restoration of the medial arch doesn't obviously go through the talocalcaneal coalition, which is rigid in their cases, but they do get a lot of rotational movement through the short part. And I think that most of our patients with, again, just the isolated medial slide, they feel they're more flexible when they're 6 months, 1 year down the line, because flexibility around the short part is possibly greater than they had with the coalition. They had a collapse situation. Now they have a nice reconstructed arch, and the short part has possibly a wider range of movement. This is what I could possibly tell the patient is. So first of all, is getting free of pain. Another one is that we get more flexibility. They would possibly move to the short part rather than the subtalar. But again, I can't prove that. I cannot prove that. There's no evidence, I'm afraid. But that's flexibility in our patients possibly would come from the short part rather than the subtalar.
Thank you very much, both. There are a few more questions, and it's been a very interesting discussion. It's a topic which obviously it's an enigma, and we don't know the perfect answers. But I think based on what I've heard from both of you, the take-home messages are that try non-surgical measurement, because there is about 1 in 3 chance it might work. Do think about deformity correction. And obviously, patients who have not improved, there is a role for fusion, resection. Be aware about incompletely resecting it if you're resecting, and do try to think about learning the arthroscopy skills. I think that summarizes it quite well, and thank you so much once again for your time. Have a pleasant evening, and a date for your diary for the next master technique. It will be on the 24th of January, Tuesday, and the topic is talar cartilage lesions, osteochondral lesions of talus. So please note it for your diary. Do not forget to give your feedback through the QR code, and have a very pleasant evening. Thank you very much for joining us tonight. Thank you.